Nothing is moving through the gut. Literally nothing. And the vomiting, the distension, those high-pitched sounds, yeah, that is the bowel absolutely screaming for help.
Welcome back. Today we're tackling a massive intestinal traffic jam that you absolutely have to know how to clear. Not just for your NCLEX, but for your future patients. We are breaking down the small bowel obstruction. So let's jump right in and get you ready to crush this. Section 1. Pathophysiology. The traffic jam.
So I want you to picture a small bowel obstruction, an SBO, as a literal traffic jam inside the intestines. You've got this roadblock, right? And because the contents just can't move forward, all that fluid and gas starts backing up proximal to the block. That means above it. The belly swells way up, and peristaltic waves literally crash against the intestinal wall trying to push things through. Meanwhile, the distal bowel, the area below the blockage, well, it completely collapses because absolutely nothing is getting through.
Let's break down how this builds, step by step. First, you get the blockage itself. Second, all that backup of fluid and gas causes massive distension. Now, step 3 is where things get really dangerous, third spacing. The pressure inside the bowel is rising so fast that it impairs absorption, and it actually pushes fluid out of the gut tissue and straight into the bowel lumen. This third spacing robs the rest of the body of fluid, leading to some severe dehydration. And finally, step 4. Because nothing can go down, well, it comes back up, causing intense vomiting.
Now, there are two main types of roadblocks you're going to see. First up are mechanical obstructions. Think of this as a physical block. The number one cause, and hey, this is a huge NCLEX pearl, is adhesions, which is just scar tissue, usually from a prior abdominal surgery. Other mechanical blocks would be things like hernias or tumors. Then, on the flip side, we have functional obstructions. You'll hear this called a paralytic ileus. This isn't a physical wall, it's an engine stall. The bowel muscle just completely stops working, usually because of post-op anesthesia, opioids, or even low potassium.
Section 2. Core signs and symptoms. All right, so what does this actually look like at the bedside? First, you're going to see colicky, crampy abdominal pain as the bowel really fights that blockage. Second is visible distension. Third is the vomiting, but pay attention to the progression here. Early on, it's bilious, meaning it's green and coming from the proximal upper GI. But if that block is lower and it sticks around, it turns feculent. And yes, that literally means vomiting stool. Fourth is obstipation. That means absolutely zero stool or gas is passing below the block. Finally, listen to those bowel sounds. Early on, high-pitched and hyperactive as the bowel tries to push through. But late in the game, the bowel gets totally exhausted and goes completely silent.
So how do all these physical symptoms mess with our lab values? Well, because of all that vomiting and the massive third spacing we just talked about, electrolytes like potassium, sodium, and chloride are going to drop fast. Potassium is absolutely critical to watch here. Next up, the pH. Since the patient is throwing up highly acidic stomach contents, their blood pH is going to shift right into metabolic alkalosis. And lastly, their BUN will be elevated. Now, this doesn't automatically mean kidney failure. It's actually hemoconcentration. The patient is just so dehydrated from third spacing that their blood has become incredibly concentrated.
Section 3. Priority Nursing Interventions.
If you remember absolutely nothing else today, memorize the SBO trio. These are your top priorities. Number 1, NPO, nothing by mouth. We have got to rest the bowel and stop adding traffic to the jam. Number 2, NG tube 2 suction. This decompresses the bowel, actively pulling out that trapped fluid and gas to relieve the distension and honestly just stop the vomiting. Number 3, IV fluids and electrolytes. We have to aggressively replace the volume and the potassium the patient lost to third spacing, and of course monitor that intake and output strictly so we know those kidneys are still getting perfused.
Section 4. Danger, strangulation, and complications.
Listen, a simple obstruction can turn fatal incredibly fast if it progresses to strangulation. This means the blood supply to the bowel has been completely cut off, which leads straight to ischemia, necrosis, and perforation. So how do you spot it before it's too late? Watch for the shift. If your patient's colicky, crampy pain suddenly shifts into severe, constant pain, massive red flag. You add in a fever, tachycardia, elevated white blood cells, high lactate, or rigid peritoneal signs, you are looking at a surgical emergency. The bowel is dying and they need an emergent laparotomy immediately.
Section 5. NCLEX Test Yourself Quizzes. Let's test this out. Question 1. A client with a small bowel obstruction has a nasogastric tube set to low intermittent suction. The primary purpose of the NG tube is to A. Provide nutrition, B. Administer medications, C. Decompress the bowel by removing fluid and gas, or D. Measure gastric pH only. Drop your answer in the comments. I'll give you 3 seconds. 3, 2, 1.
The answer is C. NG suction decompresses the GI tract proximal to the obstruction. Think of it as the ultimate pressure release valve. By sucking out that backed-up fluid and gas, you relieve the dangerous distension and stop the nausea and vomiting, all while giving the bowel the rest it desperately needs.
Let's try question 2. A client with prolonged vomiting from a high small bowel obstruction is most at risk for which acid-base imbalance? A. Metabolic acidosis. B. Metabolic alkalosis. C. Respiratory acidosis. Or D. Respiratory alkalosis. Think about what is physically leaving the body here. 3, 2, 1.
The correct answer is B, metabolic alkalosis. Remember, stomach contents are highly acidic. When a patient has prolonged vomiting, or when we are aggressively suctioning with an NG tube, we are actively depleting their body of hydrogen ions and chloride. Losing all that acid leaves the body in a primary state of alkalosis.
Think about it. Could recognizing a subtle shift in bowel sounds be the very thing that saves your future patient from a fatal perforation? It absolutely could. To wrap this all up, lock this memory hook into your brain for exam day. The SBO trio is NPO, NG decompression, and IV fluids. Rest it, empty it, and hydrate them. If this made it click, subscribe. One killer med search topic every day until you pass the NCLEX.